Good morning. Thank you for having me, Dr. Savitz. So this morning, we're going to discuss what the current evidence shows about GLP-1 receptor agonists in stroke prevention. There's a lot of information about these drugs in the media as well as in the medical world. And so what we really want to consider is, as stroke neurologists, as clinicians, as stroke survivors and care partners, how should we be thinking about these medications, and should we be using these medicines in stroke patients? And if so, for which ones should we really use them for? So, to get it started, I just want to go over just the basics. We were a mixed group. So I know some people may not be as familiar with what these medications are, but GLP-1s, receptor agonists, are basically like a natural hormone that's in your body. It is called GLP-1, which stands for glucagon-like peptide 1. And it's a hormone that is released in the intestine. Basically, it does two things. It lowers your blood glucose, so your blood sugar, after you eat. And it does this by stimulating insulin secretion. And then it also acts centrally in the brain, specifically in your hypothalamus and the brainstem, so which are two areas in the back and sort of deep portions of the brain. And what it does, it suppresses someone's appetite, and it also slows down gastric emptying, which is just as the food moves through your body. GLP-1 receptor agonists are synthetic versions of the GLP-1, and they mimic the hormone, but they're different because they're engineered to resist degradation or breakdown. So normal occurring GLP-1 that the body makes, it typically lasts like a couple of minutes, but the synthetic version lasts longer. The first FDA-approved medication that was in this class of medicine was approved for glycemic control, specifically in patients with type 2 diabetes. And the name of that medicine was called exenatide. Since then, there have been several other other GLP-1 receptor agonists that have been developed. And they now have indications for obesity or overweight patients who have a BMI greater than 27. And then most recently, there's now a liver indication for people who have classically what we knew as like fatty liver disease. So the reason why this class has generated so much cardiovascular interest is because it actually goes beyond just glucose lowering. It actually has several pleiotropic effects, which we'll talk about in the next slide. So GLP-1 receptors are not just confined to the pancreas. They're expressed across a large range of tissues, including your heart, your blood vessels, the kidney, the liver, and your fat tissue, as well as in your brain, your central nervous system. And this is really the biological basis for why these drugs are so important, more than just lowering your glucose. At a systems level, they can improve insulin sensitivity. So, like diabetes, especially type 2 diabetes, this is an insulin sensitivity problem where your body creates insulin, but the tissues are not as sensitive to the actions of insulin. So, it can help to increase the body's insulin sensitivity. It reduces fat accumulation in your liver. It can promote the excretion of sodium in your kidneys. It can reduce inflammation, both vascular inflammation and systemic inflammation, which is important for atherogenesis. And it also has like direct protective effects on the kidney and the heart and the cerebral vasculature, which we'll sort of go over more specifically in the next slide. So in regards to the cardiovascular mechanisms that GLP-1 receptor agonists show, specifically in the myocardium or the heart, which is towards the left side of the screen, there's a picture where it shows that GLP-1 receptor agonists, they can reduce injury to the heart and preserve the function of the left ventricle in the heart. So they do this largely by preventing apoptosis of cardiomyocytes, which basically means like death of the cardiac muscles. And they also help to protect against what we call overload-induced hypertrophy. So for instance, the reason why we talk about why high blood pressure is so bad for people is that it's almost like you're putting a weight on top of your heart and telling your heart to continue to function like it's supposed to. So it really can help to protect the heart tissue. In regards to the vascular protection that it gives, this is towards your right at the bottom. That's sort of the picture showing what GLP-1 receptor agonists could do at the vascular level. The drugs really decrease systemic and vascular inflammation, and they do this by decreasing what we call hematopoietic stem cell proliferation. And this matters because that is sort of what feeds the inflammatory cells that cause the plaque to build up. They reduce foam cell formation, and these are the earliest steps to atherogenesis or the plaque formation when people say you have clogged arteries. So when you put this together, you end up with reduced plaque size. So in this picture, you see sort of like this yellow plaque that's there. That's what we're talking about towards the far right. It's important because I'm not sure if y'all can see it, but for strokes are caused by a lot of different things. One of the causes of ischemic stroke is what we call large artery disease, and that's the plaque in the arteries. 25% plus of strokes are caused by this very reason, and that's just for ischemic stroke. And when you have the ability to stabilize the plaque, decrease the inflammation, that can help prevent rupture of plaque. So what we don't want is, the plaque to be unstable or soft and prone to rupture. There are specific neuroprotective effects of the GLP-1 receptor agonists. So just beyond the vascular effects, there's a growing body of preclinical work that's being done in this area that shows that GLP-1 receptor agonists can have some direct neuroprotective properties in the setting of acute ischemia. So this is when someone has had a stroke. What are some of the things that we're seeing in preclinical studies that show that it might be helpful? So some of the proposed mechanisms say that GLP-1 receptor agonists can have an anti-apoptotic signaling in neurons, reduce the oxidative stress, bring down the inflammatory cascade that can happen after someone has had a stroke. It can also preserve the blood-brain barrier. A lot of that is a lot of sort of like physiological clinical talk, which just means that GLP-1 receptor agonists can actually help to bring down the damage that's occurring right when ischemia is taking place to try to preserve brain tissue from infarcting or dying. So now I want to move over to exactly what has been done in terms of clinical trials. This table, it's a table about different trials as well as some meta-analyses, which basically just means that it's like a group of different clinical trials that they did, that they looked at the data together to help us understand what these drugs are doing in terms of cardiovascular outcomes. And the table, it's sort of going in chronological order. And the first study was called LEADER. It happened in 2016. And this study tested liraglutide in patients with type 2 diabetes and high cardiovascular risk. So basically, these are patients who'd had a heart attack before, they had coronary artery disease, so maybe they'd had a stent before, they'd had a stroke, a TIA. So these are people who already have underlying cardiovascular disease and type 2 diabetes. And what they looked at the incidence of major adverse cardiovascular events, which is denoted as MACE. So when you see MACE, that stands for major adverse cardiovascular events. And so there are three specific things that they're looking at. They're looking at cardiovascular death, they're looking at non-fatal strokes, and they're looking at basically non-fatal MI. So heart attack, strokes, and a death because of a cardiovascular reason. And so when they looked at these composite events in leader, they found a 13% reduction in the patients that took the medication, the GLP-1 receptor agonist. Later on that same year, they did another study called Sustain 6, which tested another GLP-1 receptor agonist called semaglutide. And it was in a similar population, and they found an even larger reduction, 26% MACE reduction. In looking at the data for the Sustain 6, they actually had a 39% lower risk of experiencing a non-fatal stroke compared to placebo. In 2019, excuse me, they did another study called Rewind, which tested dulaglutide in a population that included many patients who actually did not have established cardiovascular disease. Remember, as I started, I said a lot of the patients, the first trial that we talked about in 2016, these patients already had cardiovascular disease. But as you went on, they started to add patients. It was still a mixed group, but some people had not already had a stroke or had not already had a heart attack. And so, again, established in this one a 12% MACE reduction. As we go on, I'm not necessarily going to go through every single one of these slides because I know we have a mixed group and we have more things to talk about. The big picture is that in this class of drugs, over the years, over about a 10-year period, multiple clinical trials, multiple meta-analyses showed that the drugs work to help bring down cardiovascular events in patients who have type 2 diabetes, as well as patients who have cardiovascular disease. So based on the indication, it's clear that we should do it. This is a stroke conference, and so we'll look specifically at the stroke data and what it shows for stroke. So in terms of looking at stroke prevention, we talk about primary prevention and we talk about secondary prevention. Basically, primary, you've never had a stroke before. We want to prevent your first stroke. Secondary, you've had a stroke. We don't want you to have another one. So specifically, when we look at primary stroke prevention, the strongest single paper that's been published is called the Rewind Stroke Analysis. It was based on the Rewind trial. And in the Rewind analysis, they roughly had, in the Rewind trial, roughly 69% of the population actually did not have cardiovascular disease. So it wasn't a trial that necessarily was set out to say we only want to recruit people who've never had a cardiovascular event, but a large population had never had a cardiovascular event before. And so it is likely the most primary prevention-enriched randomized trial that we actually have. And in this study, they were looking at dulaglutide, and it was able to reduce all stroke by 24% with a hazard ratio of 0.76, and specifically 25% for ischemic stroke, with a hazard ratio of 0.75. Hemorrhagic stroke was not reduced, and it's actually a pattern that we would go on to see. So specifically, when we think about ischemic stroke, that GLP-1 receptor agonists, when they looked at a trial that had the vast majority of patients without any sort of prior cardiovascular disease, it did work to decrease significantly the amount of first-time ever strokes. Following this, in 2020, there are two meta-analyses that were conducted, and basically both converged on having a 16%, thank you, a 16% reduction in stroke. Let's see, the second of these, they found that the cardiovascular benefit, it didn't differ based on whether patients had established cardiovascular disease at baseline, which was sort of a hint, an early hint that said that it might be a little bit more generalizable even to secondary prevention populations. So essentially, when looking at the table, the summary is that primary stroke prevention, it is a clear signal that it's real and fairly consistent across the class of medication. It's most consistent in populations with type 2 diabetes, and it gets less certain as we move towards other populations that do not have diabetes. Okay, the next slide I want to talk about is for recurrent stroke or secondary stroke prevention. So the data is a lot more limited in this regard. For secondary prevention, the most direct data that we have comes from a Chinese trial called the LAMP trial. It was published this year, and the LAMP trial, it occurred in China, and it randomized 636 patients who had type 2 diabetes and either a minor acute ischemic stroke or a high risk TIA to a GLP-1 receptor agonist called liraglutide. And so did this plus standard care versus standard care alone. And the participants had to be enrolled within 24 hours of their symptom onset. And so at 90 days, they checked to see how many of the participants had had a recurrent stroke. And they found that in the liraglutide group, 7.9% of the population had had a stroke versus 13.8% of the standard care arm with a hazard ratio of 0.56. And so it's meaningful because the effect size is clinically important. And it's actually the first randomized trial that we specifically have that's designed around secondary stroke prevention in this class. So it's purposefully built to measure secondary stroke prevention. The other trials that had been done earlier, they were based on like post hoc analyses, they were subgroup analyses, there were meta analyses that had not been specifically designed to look specifically just at stroke. The other data points that we have about recurrent stroke are a subgroup analysis. We have a post hoc analysis that combined the data from the Sustain 6 and Pioneer 6 trials. And it looked at the subgroup of patients who had had a prior stroke and found a hazard ratio of 0.89 for any recurrent stroke. But it did have a wide confidence interval. So, in terms of it being statistically definitive, that's not clearly established. And then in 2025, they had a meta analysis of randomized clinical trials. They had 11 trials and over 85,000 patients that they pulled together. And in that trial, they had a hazard ratio of 0.73. So with a hazard ratio, the lower the number, the better it is. So overall, LAMP is encouraging. It's the first trial that was like purpose built for this question about whether or not we should be giving patients who've had a stroke initially a GLP-1 receptor agonist. It's one trial that was done in one country with likely a pretty homogenous participant pool. So that's another thing we have to take with a grain of salt. Is that you would really need to see trials that are done in other countries and other races to see how it performs. So when it comes to patient selection, we're going to spend a little bit of time sort of talking about this because ultimately this is what we're talking about. Like who should be receiving GLP-1 receptor agonists, who has evidence to support the use of GLP-1 receptor agonists in the population. I'll tell you honestly, before this, I would look to see who was on a GLP-1 receptor agonist, and after now, I'm specifically asking patients who are not on a GLP-1 receptor agonist why they're not on one. So it definitely changed my clinical practice to make sure that I'm paying a little bit closer attention to this. So we'll just go row by row here, actually. So for patients with an ischemic stroke or TIA and they have type 2 diabetes, based on the data, we really should strongly be recommending that these patients should consider going on a GLP receptor agonist because it has shown some proven cardiovascular benefit. And that's assuming that they don't have some other contraindication specifically to that medication or drug class. And this has really strong evidentiary support. So the American Diabetes Association, their 2026 guidelines are recommending GLP-1 receptor agonists in patients with type 2 diabetes and established atherosclerotic disease or multiple risk factors for it. So if you have a patient coming in with stroke, specifically, especially if it's large artery disease, they definitely should be on a GLP-1 receptor agonist, irrespective of their A1C. So even if they have a controlled A1C, it's less than 6.5%, but they have type 2 diabetes, they've had a stroke before, we should consider putting them on a GLP-1 receptor agonist. In terms of patients with a prior stroke who don't have diabetes, but they're overweight, they have a BMI that's greater than 27, we should also strongly consider putting them on GLP-1 receptor agonists, specifically considering using semaglutide. And I'm sorry, I don't know the brand names for all of these medicines. So I'm sure we probably know the Ozempics of the world and Wegovy and Mounjaro, but I'm sure it would probably have been helpful. But semaglutide 2.4 milligrams, if there's no contraindication, because there's also just strong evidence for that. There's an FDA indication for, I know this one, Wegovy, and that explicitly covers reduction of cardiovascular death, MI, and stroke, specifically in patients who are overweight. So they don't have to have diabetes, and this is built it's built on the SELECT trial that we talked about earlier in the table. For a patient who's obese or overweight, greater than 27 BMI, and they have a weight-related comorbidity. So this is not necessarily someone who's had a stroke before, but they are just either overweight with a BMI greater than 27, and they have a weight-related comorbidity. So weight-related comorbidities would be things like high blood pressure, obstructive sleep apnea, high cholesterol, liver disease. These are patients who we without one of the indications. So they don't have type 2 diabetes, they haven't had a stroke or heart attack, you should consider using a GLP-1 receptor agonist on them. And that's under an approved weight management indication. The evidence here is a little bit more moderate than the prior two, but it's not strong, but it's still something that could be discussed with the patient. For a patient with a prior stroke who does not have diabetes, they are not overweight, they have no other approved indication, the current evidence does not support just putting these patients on GLP-1 receptor agonists solely for recurrent stroke prevention. There's no guideline recommendation. It would be off-label use. There will be more studies that need to occur to look at this specifically. For hemorrhagic stroke survivors, there really is no randomized data that establishes that a GLP-1 receptor agonist should be used in this population. So in summary, if I can leave you with one sentence from that slide, it's that current evidence supports, it's well established that if you have a metabolic or cardiovascular indication, then you should be on a GLP-1 receptor agonist. For the stroke population, diabetes and stroke, GLP-1 receptor agonist, overweight and stroke, GLP receptor agonist. Specifically looking at the semaglutide, 2.4 milligrams. Stroke by itself is not an indication. If you are someone who's overweight and then you have the metabolic comorbidities, then that's something to kind of explore a little bit further with your doctor. In terms of broadening utilization of GLP-1 receptor agonists for stroke, we know that it's a class-wide thing. There's been landmark cardiovascular outcome trials and meta-analysis that have proven that GLP-1 receptor agonists can reduce major adverse cardiovascular events and stroke risk. It's clearly established in patients who have diabetes, obesity, or established ASCVD or atherosclerotic cardiovascular disease. The evidence is not yet strong enough to recommend a GLP-1 receptor agonist as a standalone secondary stroke prevention therapy because the existing data has been derived from populations that were selected because they had type 2 diabetes or because they were obese or had high metabolic risk. For patients with normal body mass index, so normal weight, no glucose intolerance, and no liver disease, prescribing a GLP-1 receptor agonist is off-label. I actually don't know anyone who does this, but it's something that we will think about in the future. So in terms of future directions, there are specific things that probably need to be done in order for us to move the science forward, in order for us to broaden the indications for GLP-1 receptor agonists. So specifically, to get a stroke-specific indication, so recently they just did one for like fatty liver disease. To do something like that, we would need to do like a large phase 3 randomized clinical trial, specifically in ischemic stroke or TIA patients. So kind of like what they did in China, but more, and just broadening the participation. And we'd have to have pre-specified primary or key secondary endpoints. So although it was measured in the earlier studies that began in like 2015s and 2010s, early 2020s, like Sustain 6, those trials were not really designed or powered to look at stroke by itself. They used a composite endpoint. And so we would need to redesign trials that looked at stroke specifically. In terms of figuring out the benefit independent of diabetes, so not everyone who has strokes have diabetes or glucose intolerance. So if we want like a blanket recommendation that if you have a stroke, you should go on a GLP-1 receptor agonist, then we'd either need to enroll a substantial number of patients without diabetes, like I think earlier the Rewind trial where they had almost 70% who didn't have cardiovascular disease, something like that, where we have so much that we can kind of start extrapolating from that. Also, the same thing for obesity is we'd have to include a lot of normal weighted individuals to make sure that we're not sort of confounding what we're seeing with the others, as well as liver disease. In terms of dedicated recurrent stroke evidence, the LAMP trial, like I said, is the first one that's been done. I'm sure that there are plans that will likely redo that. It seems that that's kind of how these stroke trials go. Maybe we start in China, we do a large trial, and then the United States and other places do more of a larger international trial. Other things that we can think about is looking at stroke subtypes. So earlier in the talk, I alluded to the fact that like maybe 25% of ischemic strokes are caused by large artery disease or basically like plaque in the artery. So one thing that we could look at is to say, well, specifically for this indication, should we do it? So something we do in stroke now is if you have severe plaque in the intracranial large arteries, we put people on dual antiplatelet therapy. That is a subtype specific recommendation by a type of stroke. So we could also consider looking at it that way. Other things that we need to make sure about the safety and the tolerability after stroke. I'm not sure how many people are familiar with GLP-1 receptor agonists, but it can cause some GI upset and irritability. So some people are not able to really tolerate, using these medications. So we'll have to look at that. And then even the way the medicines are administered, I think, in the news, they've talked about how there's a pill version coming out. Some people don't like to give themselves injections. So really it's thinking about the science, thinking about how it's going to be, how it'll be delivered, the acceptability to patients. These are all things that have to be considered as we think about making sort of a blanket recommendation for stroke patients that go outside of diabetes and obesity management. So this is my last slide in conclusion. Evidence, again, strongest for primary prevention of first stroke in patients with type 2 diabetes and higher cardiovascular risk. There's some evidence there. Trial evidence shows that GLP-1 receptor agonists, they can reduce early recurrent stroke in patients with type 2 diabetes. That's based on the LAMP trial, that statement. We still need confirmatory trials and data in patients without diabetes, without obesity, and without liver disease, because that is currently what the indications are for. So I expect fully that in the future that we will start seeing trials that are testing exactly this in the stroke world. That's it. A lot of references there. Okay.